Respected panelists of the session and learned audience, Assalamu alaikum. I am Dr. Tomal from NICBT Dhaka. And my topic is to seal or not. I will present three cases. My first case is a 60 years old lady, presented with 4 hours of chest pain and shortness of breath, and she was in cardiogenic shock. And there is ischemia in the ECG. There is ST elevation indeed V1 to V5. So we did the echo, and there is anterior and anteroseptal echinacea. We proceeded for primary PCI like strategy. So there is LED is diffusely diseased, and it is totally occluded after the D1. So we proceeded for primary PCI. We wired the LED, and we ballooned the LED by 2 into 20 millimeter balloon, 70 compliant at 10 ATM. Then we dilated and put a stent 2.5 into 14 millimeter at 10 ATM. So things were going well. This was the outcome after the stenting. So, but we saw there is some leaking of jet from the distal part of the stent without persistent staining from the distal part of the stent. So after the deployment of the stent, there is a perforation happened in the distal part of the stent. So patient was quite stable hemodynamically, and bedside echo showed there is no pericardial tamponade. So we proceeded for low pressure balloon inflation 2.5 into 12 millimeter at 4 ATM for about 6 minutes. And this is the prolonged balloon inflation. And we can see the jet is still going outside from the distal part, but patient was hemodynamically stable. So actually the jet was going to an cavity, and it is behaving like a coronary cameral fistula. It was actually exiting into the left ventricle. So it was the type 4 perforation leaking into the another cardiovascular cavity. This is type 4 perforation. Patient was hemodynamically stable, and we ended the procedure here. So the guideline says in type 4 perforation, we check for hemodynamic instability. We initiate a low pressure balloon and call for surgeon for urgent CVG if needed. And in our case, we identified that the cavity was LV, and that is patient was hemodynamically stable. So this is a low pressure cardiac chamber, and there is no intervention required. And we stop the procedure there. So this is type 4 perforation. Now my second case, Mr. X, 60 years old, anterior. The CAG shows there is some intermittent lesion in the LCX, and LED is disease, some tight stenosis in the proximal part, and distal LED is diffusely diseased. We had the plan to PCI to LED. We wired the LED and pre-dilated with the 2.2 into 12 millimeter balloon. So we did the pre-dilation. Things were going well. Then we stented the LED in the distal part in 2.75 into 38 millimeter drug-eluting stent. This is the distal part of the stenting. Then we pre-dilated the proximal part and put a second stent 3 into 80 millimeter drug-eluting stent overlapping the distal stent, and things were going well. Patient was hemodynamically stable. But one of our curious mind, he noticed something going outside in the distal part of the LED, and there is a jet in the distal part of the LED without patient going hemodynamically unstable. So we thought this is type 3 perforation in the distal LED. Frank steaming of contrast through 1 millimeter hole, exit hole. As the patient was quite hemodynamically stable, we went to the prolonged balloon inflation about 6 minutes by 2.25 and into 20 millimeter. And we are lucky that patient was hemodynamically stable. And this is the final outcome. You can see there is no further leaking of jet in the distal part, and patient was hemodynamically stable. There is no pericardial effusion or tamponade. We ended the procedure here. And my third case, Mr. X, 55 years, CCS class 3 angina, ETT positive. And in the left side, there is no significant lesion. And in the right side, there's a lesion in the PDA, proximal part of the PDA. As patient was symptomatic ETT positive, we had the plan to PCI to RCA. we wired the RCA and we did the P-dilatation of the RCA by 2 into 12 millimeter balloon. Then we had a plan to stent the PDA. We took 2.75 millimeter into 20 millimeter stent, and we had no 2.5 millimeter stent at that time in our hand. And you can see after the stent balloon inflation, there is some leaking jet here in the distal part of the stent. And we took further views, and you can see there is a jet in the outside part of the stent from the distal part, and the jet is continuous with the stent. So this is type 3 perforation. We again did the prolonged balloon inflation at low pressure about 6 minutes, and we are lucky that patient was reasonably stable. There was no pericardial tamponade. But even after balloon inflation, we can see patient is going to hypotension, and he needed inotrope support. So we had the plan to give the cover stent here. So we took a second wire, and by the help of the second wire, we took the graft master cover stent here. Size is 2.6 into 18 millimeter, and we gave the cover stent, and patient became hemodynamically stable. And you can see the staining is not continuous with the stent here. So patient was hemodynamically stable and good TB3 flow. We ended the procedure. So my take-home message, sir, coronary perforation is rare but life-threatening, and incidence is 0.84% of the PCI. Class 1 and Class 2 perforations are usually managed conservatively without any specific treatment. Class 3 perforations are very dangerous, and as with development of tamponade and need for bypass surgery and a very high mortality. Type 4 perforation is the rarest variety. I showed it in my first case. Tortuosity classification, higher stent to vessel ratio. Second infection of a semi-compliant stent balloon is in a small caliber artery might be the causes of perforation. If perforation occurs, make sure you don't lose your water position. Prolonged balloon infection at perforation sites buys time, decreases the likelihood of tamponade, often good enough to seal. Stat, echo, and urgent pericardial synthesis is often needed. A second support wire and often a second guide catheter are helpful to deploy a covered stent when indicated. Notify surgeons early if urgent CBC is needed. Thank you. This is my team in NICBD. I showed 3 cases as learning curve. Thank you.
Thank you very much.